So a few years ago, a drug company based in California called Gilead developed a treatment for hepatitis C. In fact, the treatment called Sovaldi is 12 weeks of pills. And after these pills, you are cured of the disease once and for all. Amazing, right? Typically, when we think about drugs, we think about taking them for the rest of our lives. Here, a drug company figured out a way to actually eliminate the disease in those who have it. An amazing accomplishment, I have to say, especially when you think about what the toll of the disease is. In many cases, it involves liver cirrhosis, so you're going to need to have a liver transplant, and death is not uncommon in this particular case. The cost of a liver transplant back in 2011 is more than $500,000. And if you think about the loss of life, the US government has actually produced an estimate of what a human life is worth. You might think that that's a rather macabre and obscene, but the fact is that all sorts of government policies require making a trade-off between how many lives saved versus how many lives hurt. And so the value of a statistical life, that's the term that's used, is $9.1 million. That's what you guys are worth. Did you not know that? Of course, I think you're worth more, but that's what the government thinks you're worth. $9.1 million. So if you save a life after a third, you're saving 2/3 of $9 million, or $6 million. That's a lot of value. So let me ask you a question. Given that this is what we've been able to avoid with Sovaldi, what do you think this drug is worth? What do you think it should be priced at? What would be a reasonable price from your perspective? Any guesses? If you know the answer, don't shout it out, because I want people to really wrestle with this issue. What is this incredible, life-saving, transformative breakthrough therapy worth to you? Anybody? Yeah.
At least the cost of the liver transplant, because...
At least the cost of a liver transplant, $500,000, right? Or, I don't know, would $1 million be outrageous? Yeah.
I think if you're the one dying, you probably pay whatever you can. Right?
You pay whatever you can. I mean, that's the sad fact. It is, isn't it? If it was your child that had this disease, I know for a fact that most parents would pay whatever they have. You know, you want my kidney? I'll give you my kidney to save my child. There is not a number that you wouldn't pay. It's an incredible, incredible boon to be able to save somebody's life with 12 weeks of pills. Well, you don't have to pay that. It turns out that the cost of a bottle of these pills, the list price, which nobody pays, everybody gets discounts, but the list price is $84,000. $84,000. Now, just by way of comparison, if you have leukemia, God forbid, and you're on a drug like Gleevec, which is a transformative drug for patients with chronic myelogenous leukemia, a year's worth of Gleevec is a little over $100,000. And you have to take that forever. For as long as you live, in many cases, you need to be taking Gleevec at $100,000 a year forever. This, $84,000, 12 weeks, you're done. What a fantastic bargain, I thought, as an economist. And yet, when this drug first came out, and when this price was issued, huge amount of negative press and pushback. In fact, Congress dragged the CEO of Gilead before it and tried to shame him and say, how can you possibly have the conscience and the gall to charge these outrageous prices? And I have to say I was totally confused. I didn't get it. Because you've got a life-saving drug here that's a cure. It's not a chronic manageable condition. It is a cure for $84,000. And what made it more difficult for me is around the same time, Tesla, the electric car company, they introduced their Model S sedan. And I went on their website, and I was completely taken with this car, beautiful vehicle. Took it out for a test drive. I did all the things that these Tesla owner wannabes do. And I configured the car that, that was the version I wanted. And I pushed the button. I waited, patiently for the estimate to come back, and it came back at about $84,000 for a Tesla. And I was wondering to myself, how come Congress never dragged Elon Musk before it and argued with him about why he wasn't cutting the price and being such an unconscionable capitalist pig in trying to charge $84,000 for the Model S? And it took me just a minute to answer that conundrum. It's because you don't need a Model S to live, whereas you do if you've got hepatitis C, you need Sovaldi. Now, that's not what I told my wife. I tried to argue with her. Yes, I really need a Tesla to live. She didn't buy that. But the fact is that there's an ethical issue with medicine that there isn't with other commodities. And so it's not just an economic issue. It turns out that the reason there was so much pushback was not because people didn't think it was worth it. It is a great bargain from a pharmacoeconomic perspective, from the cost-benefit perspective. The problem is that it's a one-time payment. And right now, there are about 3 million Americans with hepatitis C. If you want to pay $84,000 for 3 million people in 1 year, that's going to wipe out most of these health insurance companies very, very quickly. It's not feasible to do that. And why should we have to do that? See, it occurred to me that when you buy these pills, what you're buying is life. You're buying a cure. But what people usually do when they take medicines forever is they're actually renting health. Buying cures versus renting health. That's the basic way of thinking about it. If instead of charging $84,000, if Gilead had said at the beginning, you know what, we're only going to charge you, I don't know, monthly payments of $890 a month for 10 years. We'll spread out your payments. We'll give you a drug mortgage. That would have actually changed a lot of the dynamics. So let's apply this. Let's use the mortgage formula, the value of an annuity, and take the $84,000 list price and spread it out over 10 years. At an interest rate of 5%, we're looking at car payments or drug payments of about $890 a month, which is expensive. It's a really nice car, like a Tesla, or a life-saving drug. Would you be willing to spend $890 a month for your child or your parent to help them buy a cure by renting health month by month? Now, there are all sorts of issues with this, so I don't want to pretend that we've solved the problem. But this is where finance does play a role in taking a very expensive upfront payment and stretching it out over time to make it more affordable. Affordability is the issue. And in some research that my co-authors and I did last year, we actually tried to do some analysis to see whether or not it was really workable. In other words, we actually asked the question, suppose that consumers themselves took out loans in order to mortgage their health. I know that sounds offensive. I'll come back to that in a minute. But the first question is, will it work? And we're not going to cover this in this class because I'm going to focus on the tools for being able to analyze this a little bit later on. But the basic idea is to take a page from the playbook of the consumer loan market and say, if we got lots of consumers that took all of these loans out and we packaged their loans and sold them off to other organizations like hedge funds or insurance companies or asset management companies, would the rates of return look attractive enough to raise the money to allow them to lend to these consumers? And we ran a few simulations and published a paper last year. It's in your reading, so we'll cover that later in the semester. But the bottom line is that, you know what? This is actually pretty attractive. And in one of the sessions later this semester, you're going to hear from one of the lenders that have actually offered to provide these loans if they can structure it in a way that would actually make sense for their shareholders. So this is not just a theoretical calculation, it's doable. Now, there are lots of problems with this. We have to answer the question, who actually pays? Do we really want consumers paying for their own health? Well, I would argue in the very long run, taxpayers will ultimately pay. That's what we do with a number of public health issues, and hepatitis C as an infectious disease is definitely a public health issue. In the long run, insurance companies might want to cover that, but they can't do it right now because it doesn't add up. If consumers can actually leave one health plan and go to another, you might pay for an expensive therapy in one case, and if that person leaves, you're not going to get the benefits of that person's health for your future plan participants. So there need to be legislative changes. In the short run, what we propose is that families, foundations, and yes, ultimately even patients ultimately will be bearing the burden in the short run. Is it offensive to mortgage your health? Yes, it is. But I think it's even more offensive to let people die when we have the financial means to give them access to these kinds of therapies. And also, if they start doing it, that might shame the legislators into changing the laws to allow insurance to be able to cover these cases. The question is, what can you do legally? And more importantly, what can payers, insurance companies, what can they do in order to take advantage of some of these contracts? But that's exactly the direction that we are going with this paper. So later on, I'll describe to you in more detail the techniques that we use and hopefully get you to start thinking more creatively about this. Okay, yes?
For such an expensive drug, over which period do pharma companies normally try to cover their cost?
Well, so that's also a good question. I'm not an expert on healthcare insurance, but I have dealt with a number of insurance companies in other contexts. And typically, insurers are looking out over 10, 20, 30-year horizons. In some cases, even 50 years is not too far away because when you're engaging in, say, workers' compensation, you've got very long-tail risk. And so horizons of that, couple of decades, 3 decades is not unusual. So insurance companies are by no means short-sighted. Their business is focusing on the long run. But the problem is that right now, we don't have a mechanism for being able to capture the kinds of problems that come about with people moving from one plan to another. So to be very specific, the problem is if I pay for a cure for you, the reason I'm willing to do that is because if I do that, then you're going to be healthy for the next 30 years, and you're going to be paying health premiums to the plan that will subsidize other people that get sick. Right? So actuarially, I can calculate that. I can calculate how many working years you have left and how much money you're going to be paying into the plan. And the fact that I'm going to cure you of your disease, it may be worth it unless you leave after 3 years to move out to the West Coast and go to another health plan, and I don't get the benefits. How do I deal with that? Well, one way to deal with that is to create a drug mortgage that I take on your behalf. So you're not paying for the drug at all. I'm covering you. I'm paying for it, but I'm paying for it over the course of 10 years. If after 3 years you leave my plan, the remaining 7 years of obligation follows you to the next insurance company. If I can do that, I'm all for it, and as an insurance company, I will pay for it. But right now, the law doesn't cover that. If you make one change in healthcare legislation that says pre-existing conditions includes pre-existing financial conditions, then it all works. But in order to do that, you got to get Congress to actually make that change. So that's the idea, but it's going to take some time to deal with it. So it's not insurance companies being too short-sighted, I don't think. I think it's really not being able to have the mechanism to prevent adverse selection from occurring.